We'll talk about malaria. So, if we tell you that a person is going to Africa or is coming from Africa or some part of Asia, then you should always consider mosquito-borne disease in mind. And malaria is transmitted by Plasmodium falciparum, Vivax, ovale, or malaria parasites by bite of infected female Anopheles mosquito. So, what will be the typical feature in malaria is its cyclical febrile paroxysms. It will come in episodes at the time of lysis by the parasite. And there will be some non-specific symptoms, a head to toe, anything like malaise, headache, nausea, vomiting, abdominal pain, diarrhea, myalgia, pallor, jaundice, petechiae, hepatosplenomegaly. So constitutional symptoms along with viral infection will be there in a parasite. So complications in children, it can spread to CNS and can lead to seizures and coma, or it can cause hematological abnormalities like hypoglycemia and metabolic acidosis. In adults, it leads to organ specific, not CNS, that is liver, kidney, and lungs. So it can lead to acute pulmonary edema, jaundice, or acute renal failure. And it can be diagnosed by peripheral blood smear, which is the gold standard, thick and thin. And protection is offered because of hemoglobinopathies, which is predominant in certain Mediterranean countries, hemoglobin S and hemoglobin C, thalassemia, partial immunity from previous malarial illness. So for prevention, we will give anti-malarial drugs. And antimalarial drugs can be artemisinin derivatives or chloroquine. So chloroquine, mefloquine, and hydroxychloroquine, which were given, but nowadays artemisinin derivative atovaquone proguanil is the main line, atovaquone proguanil. And doxycycline can also be given. Along with that, insecticide treated nests, household insecticide residual spraying can also help. These can help, but they cannot make sure you will never get the infection. The typical cycle is cold, hot, and sweating. In cold phase, you get chills and shivering. In hot phase, high-grade fever, and sweating, obviously sweating and the fever resolves. Anemia and thrombocytopenia are classic in this patient. Travelers get it because they don't take chemoprophylaxis, which is definitively preventive. Yeah. And how do we DD it with dengue? Symptoms in dengue develop 4 to 7 days after mosquito bite. Not about greater than 2 weeks, which can occur in malaria. In malaria, the symptoms can develop after 2 weeks, but in dengue within the first week. So let's move to recommended anti-malarial chemoprophylaxis options for short-term travelers. Let's move on to areas with chloroquine susceptible Plasmodium falciparum. So in this, we can give chloroquine or hydroxychloroquine, and it is a weekly dosing, so we have to give 1 to 2 weeks in advance, and it can also lead to potential exacerbation of some skin conditions like bullseye rash. Now let's move on to areas with chloroquine resistant Plasmodium falciparum like sub-Saharan Africa, Southern and Southeast Asia. All the drugs we will talk about can also be given in chloroquine susceptible Plasmodium for prophylaxis. So let's see. Instead of chloroquine, here we have mefloquine. So mefloquine, it is the agent of choice in pregnancy, very important. And same as chloroquine, weekly dose. And mefloquine will make you mental, that is neuropsychiatric effects will be there. Then we have the drug of choice for malaria nowadays, that is artemisinin derivative atovaquone proguanil. It is expensive, but it's good. And some GI disturbances, abdominal pain, increased LFT. Then doxycycline. Doxycycline is inexpensive, the same GI disturbance, it is also sun sensitive and teratogenic. Then we move on to areas with Plasmodium falciparum, without Plasmodium falciparum, like, oh my god, Korea, Korean Peninsula, South America, Mexico. So here we will be like we give the primary treatment, Prima Queen. Potential teratogenicity, hemolysis in diabetes with G6PD, and it is like weekly dosing.